Hi, good evening. If you're just joining us, welcome. I hope you're going to find this evening's event helpful. My name is Andy Williams. I'm the Joint Chief Executive of the 3 clinical commissioning groups in Leicester, Leicestershire and Rutland, and I'll be organising or leading this evening's conversation. We're running it as a live Teams event, which means that you get the opportunity to put questions to us, but you need to use the chat space to do that. Hi, good evening. If you're just joining us, welcome. I hope you're going to find this evening's event helpful. My name is Andy Williams. I'm the Joint Chief Executive of the 3 clinical commissioning groups in Leicester, Leicestershire and Rutland, and I'll be organising or leading this evening's conversation. We're running it as a live Teams event, which means that you get the opportunity to put questions to us, but you need to use the chat space to do that. Hi, good evening. If you're just joining us, welcome. I hope you're going to find this evening's event helpful. My name is Andy Williams. I'm the Joint Chief Executive of... I think we might be having some technical problems. Just bear with us 1 second. And I'll be organising...
I think you're clear now. I think you're clear now. I think you're clear now.
Is it okay now? Okay, good. Sorry about that. Occasionally things don't quite work as we would like. So you've probably heard me say repeatedly who I am and welcome to this evening's meeting. I'm very pleased that we're able to share with you our consultation proposals this evening. We're running it as a live chat event, which means that you get to ask us questions, but you'll need to use the chat facility to do that. Is it okay now? Okay, good. Sorry about that. Occasionally things don't quite work as we would like. So you've probably heard me say repeatedly.
Most of all, we want to deliver hospital healthcare that is fit for the future. This is your chance to find out more about what is being proposed and to have your say. This will help your local NHS understand what the changes would mean for you and help us make a final decision.
What we don't want is a health service that's designed only by the people who work in it. It's got to be designed by the people who experience it and use those services.
The proposals include 2 super intensive care units, one at Leicester Royal and one at Glenfield Hospital, with 100 beds in total. That's almost double the current number. Modernised wards, operating theatres and imaging facilities. The first dedicated single-site children's hospital in the East Midlands, based at the Royal. And a new maternity hospital. Currently, there are 2 units on different sites, the General and the Royal.
Obviously, having 2 sites means that sometimes we're spread too thinly. When we're really busy, when we haven't got enough rooms or when we haven't got enough staff to look after the women, especially in labour, women need one-to-one care. We have to transfer activity from one site to another. So we would envisage that with a new, larger hospital where we pooled the staff together, that likelihood would happen less often. The beauty of it is that they're going to be in one unit, and if there is an emergency situation, they can very quickly have access to the obstetricians and the neonatologists.
Under our proposals, Glenfield Hospital will become a major planned care treatment centre, with welcome centres to put you at ease and help you find your way around the hospital. These changes would enable us to separate emergency care and planned operations. This would help prevent treatment being delayed or cancelled when the emergency services are busy. More than 100,000 day case procedures and around 600,000 follow-up appointments take place every year at the city's hospitals. The move will free up capacity at the Leicester Royal Infirmary and help ease issues of access and parking there.
Let's take a patient, for example, who's having a planned day case surgical procedure. They will receive their pre-operative workup on this site, so all the tests and things they need doing before the operation. They will have also been seen in clinic on this site, have the decision made that they needed an operation in the first place, and they'll come to this site, they'll have their operation and go home the same day, and any follow-up that's necessary after that will also be provided on this site.
Leicester General Hospital will become a community health campus. It would include facilities such as the Diabetes Centre of Excellence, a dedicated imaging hub to help GPs diagnose patients' conditions quicker, and a stroke recovery service with inpatient beds. It would potentially be home to a midwifery-led unit, which will be relocated from St Mary's in Melton Mowbray. This will make it accessible to more people and provide a better and safer experience for mums. Today's modern medicine and technology means many patients don't always need to stay in hospital to get well.
Over the last 30 years, the NHS has cut its beds by about 50%, which feels counterintuitive looking at the population growth. But when you take into consideration the change in medical practice over the 30 years, so hip replacements used to come in and be in hospital for over a week. They're now staying in hospital for around 2 days. We've got sort of robotic surgery now and keyhole surgery, which means patients don't stay in hospital as long. And we used to prescribe bed rest for patients. We don't do that anymore either.
And for some conditions, you can be cared for at home or where you live.
If you need to be in hospital, so you need treatment or you need investigations that can't be done in the community, or for instance, you're acutely unwell and you need the investigations done straight away, hospital is the right place for patients. But there's certainly patients where their medical treatment can happen at home, and it's much nicer for the patient if you can have all the care investigations done in your own surroundings, done at local community hospitals with doctors, nurses coming in that will be the same faces that they see on a daily basis. It's about having safe care, but in the best way for the patient, the most suitable way.
At the moment, our hospitals and our staff, while doing their best, are spread too thinly, trying to provide 21st century services in outdated buildings with limited resources and opportunities for change. We want to achieve a service based on our future healthcare needs, not the legacy of the past.
Leicester's hospitals merged in 2000, and whilst that merger was very successful, it left one issue unresolved. And that was that many of our clinical services, the location of those clinical services is more a product of accident than design. They're split across more than one site. Our staff are spread thinly and our equipment isn't always in the right place. And that can lead to difficulties with staffing our services in the way that we would want to do optimally. I'm really excited by these changes. I think that this is a once-in-a-generation chance to provide care in Leicester, Leicestershire and Rutland that will be state-of-the-art. We'll give patients a much improved patient experience, give them access to modern medicines, modern treatments in modern buildings. And I'm really excited by this, and I hope that people will be when they see the plans of what we're planning to try and do for Leicester, Leicestershire and Rutland.
You can see the proposals on our website and fill in a questionnaire to give us your views.
Thank you. So I hope you found that video helpful. I'm sorry you may have found that we had some technical issues just at the very start, but I think that video ran properly, and I hope that's provided some helpful background information to the proposals that we're talking about this evening. The way this evening is going to work is it's running as a live event for Teams, which means that you get to ask questions if you wish. You should find at the bottom of your screen, particularly if you hover your cursor over the the main screen, a taskbar appears, and that will enable you to type in a question in the question and answer section. We'll come to those questions in order and try our best to either note the comments, or if you've put a question specifically to True, answer the question. A number of colleagues are joining me this evening, and we'll introduce ourselves as we go, and I'll put the questions to various colleagues and we'll respond. We have got about an hour and a half this evening if we need that. We may not need all of that time, we might use all of it, depends how the evening works, so we'll play it by ear. And if for any reason we don't know the answer to questions you put, or for some reason we don't get enough time to go through and answer all the questions, then we'll make sure to capture them and to provide responses via our website or directly back to you if that's more relevant. So I hope that's helpful. Tonight is part of the formal consultation, so we are capturing all of the questions and recording the presentations so that we've got that information to evaluate at the end of the consultation period. And before we close tonight, we will just say a little bit about the next steps and what happens post-consultation process, so I'm happy to turn around to that too. What I'm going to do now is invite one or two colleagues just to put some opening remarks whilst we wait for some initial questions to come in. So perhaps I could turn to John first as the Deputy Medical Director and just ask you to introduce yourself, John, and perhaps just talk a little bit about how important these changes are from the clinical point of view in UHL.
Thanks, Andy. So my name is John Jameson. I'm a Deputy Medical Director in UHL, and I'm a bowel surgeon by background. I think, as Andrew Furlong, the Medical Director, said in the video that we've just heard, this is a once-in-a-generation chance for us to really improve things in Leicester for our patients. As he said, we're sort of an accident. The way the hospitals are laid out is an accident of history rather than design, and we know that we don't give people the best experience that we can give them, but because of our configuration. We bounce people around our sites, both if they're being investigated as outpatients or even when they come in as emergency. You can often be crossing town from one hospital to another, and we know that's not a good patient experience, and this gives us the opportunity to solve some of those things. It also gives us the opportunity to solve some of the other things that we've been struggling with for a long time in Leicester. One is the number of intensive care beds that we have available to us. Intensive care is where we care for our sickest patients, and compared to some of the London hospitals, we've got half the number of intensive care beds compared to ordinary beds that they've got, and this gives us the opportunity to put that right. And the other thing that we want to try to achieve as best we can with these changes is separating elective from emergency care, because we know when we're really busy on the emergency side, sometimes we can't get through all the planned work that we would like to. And again, that's not good for patients who are teed up to have operations, have made all the arrangements in their own lives to facilitate that, and then we can't do them at the last minute. And the final thing I'd like to say is this also gives us the opportunity to working with colleagues across the whole of the healthcare community is to only bring people to the hospital when it really adds value to their care. We can do things in a much more organised way, hopefully. So if you do have to come to hospital, it truly adds value, and we can have all the information with which to make decisions, give people the best advice that we can in one visit to the hospital. So there's quite a few things that this reconfiguration gives us the opportunity to do.
Thanks, John. And let's just develop that a little more. I think we're also joined this evening by Ian, who will be able to talk a little bit more about the specific details around some of the proposed changes to women and children's services, particularly maternity services. So, Ian, are you able to join and just provide a clinical perspective on some of those changes, please?
Yeah, sure, Andy. Without going into too much detail, because we can answer questions that if people have issues that they specifically want to raise. We could have two maternity services, two big maternity services, one at the Royal, one at the General. At the moment, we offer a comprehensive range of options for women to have their babies. Our antenatal services are largely provided in the community, unless complicated pregnancy problems, in which case they'll attend hospital clinics. And after the babies are born, again, unless women have significant medical problems, which mean they need to be in hospital, in the main, they'll go home fairly quickly after having their babies, and they have most of their postnatal care in the community. So in terms of having the baby born, there are 4 basic options. One is to have the baby in one of the 2 obstetric units, either at the Royal or at the General. A second, and the obstetric units are staffed by a mixture of obstetricians who are doctors like me, and midwives. Or secondly, if they wish, women, if they're relatively low risk and uncomplicated, can have their baby in a birth centre, either at the Royal or at the General, which is staffed by midwives and is alongside the delivery suite, so that there's ready access to the delivery suite should they need transfer. Thirdly, they can choose to have the baby up at Melton at the standalone birth centre, midwifery birth centre, which is run by midwives at Melton, has no medical support at all. And so if there is any complication or any problem in labour, the woman needs to be moved from Melton. And if the baby has any problems, they need to be moved either to Royal or to the General. Or they can have their baby at home, which obviously is convenient for many women, and to all intents and purposes is very similar to having your baby in the standalone birth centre at Melton, with midwives coming to look after you at home in labour and for the delivery. Now, for a long time, it's been very difficult to run 2 big maternity units on the 2 acute sites at the Royal and at the General. It's become increasingly hard to do that. It's very hard to staff 2 sites, particularly with doctors. And as the care and complexity of care is increased, we've also had to duplicate an awful lot of facility on each of the 2 sites. All added to that, as the video and John have indicated, this is a real opportunity to really develop the acute services at Glenfield and the Royal. And to do that, we will be moving acute services off Leicester General. And so if we won't have the acute services on the Leicester General Hospital site to provide the support that's really necessary for a big maternity unit at LGH. So in fact, for about 20 years since I came to Leicester as a consultant, a bit more than that, 23 years, we have been recognised that there are some serious long-term issues with the sustainability of the 2 acute site model for maternity services. And we've had 3 large reviews over that time. First in the early part of the noughties, the second 2009-10, and the third 2016. Which all looked at a variety of options and came to the conclusion that the only real sustainable option was to have 1 site with all the co-locations that would provide. And this is a real opportunity for us to put a lot of money into maternity services and develop it for the long term. Now, we are determined that we want to give women options, and we want them to have all 4 options that NICE recommends for delivery. And that means the obstetric service, if women want that, so they can have epidurals, for example, and the obstetricians are there to deal with problems for more complicated pregnancies. The alongside birth centre, which is in the plans, with ready access, run by midwives, but with ready access to delivery suite should that be necessary, for obstetric, anaesthetic, paediatric reasons. Thirdly, we think it's important for there to be a standalone midwifery birth centre option. And we think that should be available to the vast majority of women in Leicester and for as many women who can access it as possible. And that's why we're proposing to put it on the Leicester General Hospital site to see whether that's something that women really want. And then finally, home birth. And so those 4 options are quite clear in the plan, and we're very proud that we're going to be able to offer these options to women, because they're not options that are available everywhere in the country. And we know that. We know they're not available in Manchester. We know they're not available in Nottingham in the same way. And we're determined that we should be able to offer women the choice that's in these plans. So those are the issues for maternity, really, Andy. I think from children's perspective, just very quickly, I think there are some really big benefits in what we're proposing for children's. I mean, one of the advantages of this plan is that we're moving the maternity service out of the Kensington building at the Royal Infirmary, and that means that we can refurbish the Kensington building and create a children's hospital, which will be the only standalone children's hospital in the East Midlands. At the moment, we're the busiest provider of children's services in the East Midlands, but the children's hospital is quite disparate. It's spread all over the Balmoral building in particular, and at the moment East Midlands Congenital Heart is over at Glensfield. So EMCHC will be coming across the Royal quite soon, and is going to be added on or incorporated into the Kensington building, anticipating then that the Kensington building can be refurbished and be designed as a bespoke children's hospital and bring all of children's services together, which would be absolutely fantastic to give them that identity, and will be really good for paediatric and children's services in Leicester and in the East Midlands as a whole.
Thanks, Ian. And just before we kind of move on from you, if I might, we've got a couple of questions, 3 questions already in. I will normally take them in order, but there is the third of those questions submitted anonymously, does talk directly to what you've just been saying, Ian. So the question says, closing St Mary's and reducing one maternity unit across the whole of Leicestershire, and I think you've already explained that it isn't quite that kind of change, will dramatically limit the ability of pregnant women to choose their birth centre. Is this just really a large cost-cutting exercise? So I think you've explained that there's more than one choice. That was a kind of key part of what you were saying. But do you want to address the issue about choice and cost-cutting as an issue?
Yeah, cost-cutting has nothing to do with these plans at all. Absolutely nothing to do with them. What we want is for the most women in Leicester and Leicestershire to have the most options. And at the moment, there are a limited number of women that are able to have their baby at St Mary's. There are about 150, 160 babies delivered a year at St Mary's, which is a relatively small proportion, even of the women that live and have pregnancies in the adjacent geography around Melton. What we want is for women to have the option of all 4 of the settings to have their babies, as I indicated to you just before, Andy, in the introduction. And actually what we're expecting is that there'll be a much better opportunity for far more women in Leicester and Leicestershire to access a standalone birth centre if that's what they want. So I think in general, for the population of Leicester, Leicestershire and Rutland, the plans increase choice quite substantially, and it adds the option of a standalone birth centre to a very large population who at the moment can't access it because it's right up in the northeastern part of the county and it's not accessible to them.
Great, thank you. Now, Emmy has put a question also relating to this. Emmy, I can see you've asked a couple of questions, and Joan, I haven't forgotten you either, so please bear with me. But Emmy, your second question relates to the midwifery-led unit at the General, the proposed unit, and whether water birthing facilities will be available in all the suites. That's a choice which is taken by nearly 70% of women currently at St Mary. So, Ian, I'm not sure, are you able to talk to that point?
Yeah, I mean, we haven't specifically designed a birth centre at Leicester General yet, but I would expect that there would be a number of pools, and I would expect that having a pool during labour and for delivery if a woman wants would be inherent, and I would expect that it would be present in all the rooms at the Leicester General and standalone birth centre. It wouldn't be logical for it not to be. We will be having a lot of pools in the standalone birth centre adjacent to the obstetric unit at the Royal Infirmary, and I wouldn't expect that the unit at LGH should be any different from that perspective.
Excellent, thanks Ian, that's really helpful. And apologies, I'm going to go back now to the earlier question, if I might. Joan Edwards put a question about access. Joan lives in Oakham, occasionally attends for acute care for a long-term illness, and is concerned about access, given the changes described from a Rutland perspective. Mark, can I bring you in at this point just to talk generally about access issues and the range of things we're trying to do to mitigate access concerns?
Yeah, good evening, colleagues, and good evening, members of the public, and good evening, Joan. Thank you for your question. So yeah, we understand that actually if you live nearer a hospital, whether it's in Leeds, Sheffield, or anywhere else in the country, then it's easier to get to. That has always been the case, and therefore if you live in Oakham, you're slightly further than if you lived in, say, I don't know, Italy. But as I said, that's always been the case. The issue, I think, really, Ms. Edwards, is, and I don't know what your underlying health condition is, I hope it's nothing too serious. Some of the things that are taxing us at the moment are, and my colleague John Jameson said it earlier on in the conversation, it's really important that people who do come into hospital are people who need to come into hospital. So one of the first things I say in answer to your question is what we're trying to do is make sure that actually we can relocate some of our services closer to home, for example, Rutland Memorial Hospital, try and negate the need for people like you to travel in. If you have to travel in, and maybe it's an emergency because an exacerbation of whatever your long-term condition is, then clearly there'll be an ambulance there to provide you with that care, and that will be pretty same whether you lived in Oakham or Colville or anywhere else on the outskirts of our catchment area. But as I say, one of the key things we're trying to do is get as much of our care that doesn't have to be delivered in hospital delivered closer to home. There's then the issue of, okay, if you live in Oakham, and it's slightly better in Oakham than it is in, say, some of the outlying villages, you've got the issues around transport and public transport, or more precisely, with the lack thereof. And so as part of our travel and access plan that we're working on with Rutland County Council and Leicestershire County Council, we're trying to work out how we can make travel and access for people in the further away parts of our catchment area that little bit easier. Now, if you've got a car, that means we're trying to improve our car parking. If you don't have a car, or don't have access to a car, or have lost confidence in driving, then that's about how we work with both the bus companies and the travel companies and the train companies and the local councils to try and work out how we can improve the travel offer for residents of, say, Oakham or Manton or anywhere else out in Rutland. I'd encourage you, Ms. Edwards, that as part of the consultation, one of the things we're mad keen on making sure we do understand all the nuances on is travel and access. So if you haven't taken part in the actual consultation formally yet, i.e. filled in the questionnaire, put your views across, I'd encourage you to do it, because the more people who do that, the more we understand the nuances of their individual circumstances and the more able we are to address it.
Thank you, Mark. We've got another question regarding access a little further down, but I'm going to go now back to, which we'll come to in a second, but I'm going to go back now to Emmy's question, which you put earlier. Would the proposed increase in intensive care beds make the hospital better able to cope in the case of another pandemic of this scale? John, I think this might be one for you to come in actually and just talk us through the evaluation that's been done in the light of COVID. Perhaps you could just explain that to us a little.
Yeah, so the short answer to the question is yes, it would have helped us cope with the pandemic better. So basically at the peak of the pandemic, I think we were using somewhere in the region of 73 or 74 intensive care beds, and we've only got 50 established intensive care beds at the moment. So what we had to do was to spill over into theatres and into the children's intensive care unit at the Glenfield Hospital, and that had significant knock-on effects. We had to stop some of the operating we were doing, and we also had to transfer the care for quite a lot of our children to Birmingham, which was a significant problem. So in the reconfiguration, as you said, we'd have 100 beds, so we'd be in a far better position to cope, and we'd also have a completely separate children's intensive care based at the Royal Infirmary. We've also looked at there's other things we've looked at in terms of infection prevention and COVID specifically in the new build stuff, and that's a number of side rooms and the ventilation and the number of isolation rooms, and we've made changes to the plans based on that. So we've basically taken the pandemic as a bit of a wake-up call. We obviously were focusing on the infection prevention stuff in any case, because we know that some of our old estate, which is several hundred years old, is just not amenable to delivering up-to-date modern healthcare. So we were focused on the infection prevention stuff in any case. COVID's given us an even more reason to do so.
Yeah. Okay, John, thank you very much. We've got a couple of questions now from Councillor Parton. A couple of these I think may have been being answered as you joined, Councillor, so I think you probably caught Mark's answer to issues around transport. There's a question which I'll put to Ian if that's okay. Answer the feedback from mothers in the eastern part of the county regarding the likelihood of having to be moved by ambulance to Leicester only when birth complications arise. So perhaps Ian, you'd like to talk about that. And Councillor Parton, I think you may have joined just after Ian answered the question about cost cutting, but I think the answer was emphatically that it isn't in any way at all a cost cutting exercise. And Ian, you might wish, in answering the councillor's first question around transport of mothers, you might wish just to kind of re-emphasise your earlier answer to that particular point, if that's okay.
That's fine. So thanks, Andy. So the short answer to the question, how many women will need to be transferred to hospital in labour, is that, well, it depends a little bit on the women that are having their babies away from the hospital and what the characteristics of them are. But at the moment, the transfer rate in labour from St Mary's is around 20 to 25%. If you are looking at women that are really quite low risk, who've had babies before without any problem, then the transfer rate is lower than that. But if you look at women who are having their first baby, then the transfer rate is significantly higher and maybe as high as 40%. Added to that, the birthplace study, which was the national, the big national study that a lot of the safety data are based on, did show that if women do need transfer to hospital, then there are some increased chances of poorer outcome both for them and for the baby, and more complications. So it is quite a serious thing when we do have to transfer women in labour for one reason or another. But a lot of that is about selecting the right place for the right woman. Now, the other issue about funding, just to emphasise what Andy had just said, this is absolutely not about saving money. What we're wanting to do, I mean, if it was completely about saving money, then we probably wouldn't pursue offering a standalone birth centre at all. But actually, we do think it's something that's really important for women to be given the opportunity to demonstrate that they want. And so the intention is to put in place a standalone midwifery birth centre on the Leicester General Hospital site. We're not expecting 500 babies to be delivered there in the first year, but what will have to happen is that there does need to be a demonstration that it is something that does have reasonably enthusiastic support amongst a sufficient number of the Leicester, Leicestershire and Rutland population for it to have a long-term future. Now, that might mean 300 or 350 deliveries in the first year, which is about double what will happen what will be delivered at Melton at the moment. And the fact is that we can't be running a number of small birth centres around the county. We do have a defined public purse that we have to use in the best way possible. And we think that to give women the best location so that they can get access to all the options that they might want to choose is the very best way we can configure the services.
Thanks, Ian. Thank you. I'd like to move on now to a couple of questions relating to emergency care. So we have a question, first of all, about is the Balmoral emergency area to become an expanded and extended extension of the current A&E? And if so, will clinics be moved out of there and to where? And secondly, we have a question regarding emergency care for children and whether that will be incorporated into the children's hospital development. So, John, are you able to respond to those questions?
Yeah, I can start. Ian might want to add to this. So in terms of the Balmoral emergency area, there's already an extensive emergency area on the Balmoral floor, which was essentially the phase 2 of the emergency floor development. In terms of moving clinics off the Leicester Royal Infirmary site, there are plans to move clinics off the Leicester Royal Infirmary site, but there's not necessarily a plan to therefore expand a lot of emergency care into those clinic areas. The idea is that a lot of clinics will go to the treatment, to the outpatient bit of the large new build on the Glenfield site. And what I was saying before about the effect of those one-stop clinics and only getting picked up when we need to, one-stop clinics making decisions in one visit. That's the idea of trying to improve care and patient experience from that point of view.
Yeah, thanks,
and,
John.
And
Mark,
in terms of the
children's services, sorry, John, did I cut you off?
Well, I was just going to say the children's ED staying in children's ED.
Okay, thank you. Okay, thank you. So let me just see if we can pick up another question. We've got a couple of questions still on the urgent and emergency theme. We've had a question now about ambulances and the difficulty sometimes with ambulance response times. And the question is, how do we see those response times changing if there are greater distances to be travelled? So I'm not sure, Mark, is this something you might be able to talk to in terms of whether there's been modelling for ambulance service impact?
I can have a crack at that. Thank you, Andy. I mean, clearly the point about NHS plans is that we, the acute sector, the kind of the big hospitals in the city, don't plan in isolation of our other partners, whether that's GPs and primary care or EMAS and the ambulance service. I have to say that the biggest issue around ambulance response times is probably the numbers of crews that are currently being held up at the various A&Es across the East Midlands as a consequence of winter pressures and COVID, rather than travel and distance. And EMAS are rather good at deciding, for example, if you live in Oakham, whether they're going to bring you into, for example, the Leicester Royal Infirmary, or whether they're going to take you to Peterborough. And those kinds of decisions are made by EMAS on a daily basis. I rather think that actually ambulance response times, as a result of actually making the options for ambulances simpler, i.e. not pinging around 3 hospitals but 2, could improve, and not least because we won't be using emergency vehicles to transfer patients across our sites in quite the way we're doing at the moment. John Jameson, my colleague, mentioned earlier that sometimes patients can be brought into A&E at the Leicester Royal Infirmary. They'll have the diagnostic workup and we'll decide actually this is more of a respiratory or more of a cardiac problem, and they've got to be put back into the ambulance and taken then across to the Glenfield Hospital. That uses up both crews and also probably wastes a bit of crucial time in terms of diagnosis and treatment. So for those reasons, I think, in fact, we kind of know from talking to our EMAS colleagues that for those reasons, they're very enthusiastic about these plans.
Okay, thank you, Mark. And just looking through the questions, I can see, Joan, you've come back in with a supplementary further information about your personal experiences. I think just to say on that, it's difficult. I don't want to kind of get into the detail of your personal circumstances in a public meeting, although I'm sure offline colleagues might be happy to talk through that. I think the general point is that I think with our response times is that the key rationale behind some of these changes is to create a cleaner separation between planned and emergency work to improve patient experience in both regards. At the moment, because the sites deliver both planned and emergency work, sometimes those services contradict or interfere with one another. This separation will give much cleaner focus for the sites, and hopefully experience for patients will improve as a consequence. So I think that probably talks to the issue that you've raised. In terms of the emergency response, then the travel time from Oakham to the A&E is unchanged by these proposals, because of course the A&E, the main A&E site, continues to be at LRI, and it is now, of course, so that's unchanged. We are developing always, and talked just in the last week or so, specifically to people in Rutland, proposals for improved services in Rutland, and so, you know, that might help with some of the circumstances you describe. We've got a question from Dominic, which again, this may be something for you, Mark. This talks about the improvement to works and roads around LRI. If there are going to be changes at the LRI site, how's that going to impact on traffic and access issues? So perhaps you might like to just talk a little bit about those issues.
Yeah, good question, Dominic. So I'm going to start by not talking about improvements. I'm going to start by taking us back to this whole idea of separating emergency and elective care. So when we build the treatment centre at the Glenfield Hospital, that will take about half of the patients who currently are seen and treated at the Royal Infirmary up to the treatment centre at the Glenfield Hospital. Put that into some kind of context, the Royal Infirmary currently sees about 750,000 patients a year. When these plans are enacted, that will drop to just under 400,000. So as a consequence, that's probably the biggest thing we can do in terms of improving travel and access to the Royal, because we'll essentially declutter it. More services will be run out of different hospitals rather than at the Royal Infirmary, and that improves access and travel because there won't be as many patients coming into it or as many car journeys. However, we are also working with Leicester City Council on the travel and access plan for the city centre, including the Royal Infirmary, looking at everything from the equivalent of Boris bikes to tram systems. And we're also improving the ground floor and multi-storey car park provision at the Royal Infirmary, recognising even though we built a new multi-storey car park 4 or 5 years ago, it's already full at times of high demand. But the key thing, Dominic, is really to say actually the Royal will no longer be our busiest hospital site post these plans. And as you'll probably know if you know our hospitals at all, the Glenfield is a much wider, bigger, flatter campus with much more space for things like parking and frankly better road access off the A46.
Okay, thank you, Mark. I think this issue has come up quite a lot actually in terms of road access and the decongestion of the LRI site. So thank you for that question, and thanks for the explanation. We've got a question now from an anonymous questioner regarding, just to clarify, the pathway for children. So if children go to the Children's A&E and it stays where it is, how will they then be admitted to the Children's Hospital? Could someone just kind of clarify how that process will work once the dedicated Children's Hospital is opened? I'm not sure, Ian, that might be a question for you.
Well, it could be me or Mark. I suppose Mark's the SRO for the Children's Hospital.
Sorry, Mark.
I'll give it a crack. I'll give it a crack.
I keep looking at you. You should probably for that. I'm very sorry, Mark. Let me come to you.
I don't think it's materially different from the position we're in now, to be quite honest. I don't know what Mark's view would be. I don't think we've really nailed that just at the moment in terms of the design brief, have we, Mark?
I think we have, Ian. Maybe I just haven't brought you into the loop on it. So for those of you, I mean, nobody, a member of the public, will probably know this because it speaks to the fact that parts of our estate are 300 years old. But those of you who occasionally travel around the Leicester Royal Infirmary will know that there is there is a very wide service passageway that runs between the new emergency department and the Kensington building, and that will be redesigned so that we can quickly take children underneath the buildings into the new children's hospital. We've been working with parents and kids on the plans for this, and they've been worth their weight in gold in terms of the design elements of it, because one of the things they spotted was, because it's an underground corridor, it can be a little bit scary. So one of the things that we're taking into the designs for the children's hospital is how we make that a kind of welcoming environment by using some of the themes that you may know about the children's hospital, which is all designed on a bit of a space theme. So we'll make both the journey from the A&E, the children's A&E, into the Kensington building quick, but we'll also make it fun for kids, which is really important.
Great, thank you, Mark. And my apologies. Occasionally, although I try to hand the questions off correctly, I don't always get it right, but I got it right this time, Mark. So thank you for that. That's a great question and a really good answer. Thank you. Councillor Parton, thank you for your comments. I can see them in there. Please don't apologise. Look, the whole purpose of this session is to put questions directly. We try to answer them candidly. We're really grateful actually for the questions, because in very many cases people are asking those questions on behalf of others they represent, so it's absolutely right for you to do that, and we're delighted to get the questions and happy to provide a response. Hopefully we'll be very direct in our responses, positively rather than defensively. I hope you found that to be the case so far. We've got another question, Mrs. Evans, again, similarly, please don't apologise, it's absolutely fine to ask questions, please ask as many as you wish. You've put a question about the Digestive Disease Centre and where will that be located. I'm not sure if colleagues can talk to that. It might be a question for Mark or for John. Is it you, John?
Yeah, so the outpatient bit of what effectively is the Digestive Disease Centre will be on the Glenfield site. So there we're going to have a big outpatient setup and planned endoscopy. There's going to be a really all singing, all dancing endoscopy suite in the new build at the Glenfield site. Inpatient gastroenterology, so that's the medical bit of that, and is going to be on the Royal Infirmary site, as well as emergency general bowel surgery. That will also be on the Royal Infirmary site, if that helps.
Yeah, thank you very much. We've got a question put anonymously around housing development. So with around 24,000 new homes in planning for Leicestershire, excluding smaller developments, are you sure that what you're planning allows for this growth? So I'll come in a moment to Mark, if that's okay, but just to say from a CCG point of view, we are also working with the county and district councils, looking at the kind of primary and community care implications of housing growth. Obviously a very significant factor for the county and for Leicester, Leicestershire and Rutland generally. So we're approaching this a number of ways, but perhaps Mark, you might want to talk specifically about these proposals and growth assumptions.
Yeah, another good question. So I'll do the shorthand answer to it first and then perhaps elaborate. So have we taken into account growth? Yes. Do we think that our plans are sufficiently roomy in order to accommodate that growth? Yes. Is that a guarantee? No. And the only reason I say the no bit at the end of that is actually predicting in the NHS what the service is going to look like in 10, 15, 20, 30 years time is a bit of a fool's errand. You either need to be a kind of a prophet, or perhaps if you say you do know what it's going to look like in 30 years time, you're probably going to flying at the edge of the truth envelope. So the reality is we can plan broadly about 10 years in advance, and we know that 10 years in advance the population of Leicestershire and Rutland will grow by under 10%. If you look at it through the currency of perhaps beds, so how many beds we'll have, we'll grow our bed base by about 300 beds in capacity terms. Some of those will be by making some of our pathways more efficient, reducing length of stay, not bringing people in to have an overnight stay if they only have a minor procedure. And some of them will be physically new beds that we will build. But if you've seen a theme coming through a lot of what we've been talking about this evening, one of those themes is that the work of the hospital should only be really emergency work and specialist work. Anything that doesn't need to be done in a big emergency or specialist acute hospital should be thought of as something that can be exported into the community, either in GP surgeries, in community hospitals or community hubs. And that will actually, as we plan together as health partners across the system, as we do more and more of that, that will give us more room to expand should we need to. But I don't think we will, and I don't particularly want our hospitals to expand. They're quite big enough as it is, thank you very much. And I would much prefer that any resources that this frees up is spent in, for example, mental health or community care, or even, dare I say, prevention and public health. So I hope that's a sufficient satisfactory answer, but I can't give you guarantees because that would be silly, I suppose.
Thanks, Mark. And just to reiterate, from a CCG point of view, we are planning with partners, with UHL, with LPT and others, exactly the sorts of changes that Mark's described. So that is the kind of pathway process that we're committing to, and trying to make sure we've got kind of place and locality based plans that reflect that. We've also been asked in previous meetings, what about the contingency options? And to be clear, there is significant growth and development space at the sites that will be there, particularly at Glenfield. You know, there is a degree of future proofing, looking sort of 20, 30 years hence, but for the reasons Mark's described, it wouldn't be appropriate or prudent at this stage, I don't think, to say we're definitely going to build a certain number of beds or a certain number of facilities. What we have got is the opportunity to review and deal with those issues in the sort of medium to longer term, if those circumstances arise. Thank you. We've got a further question from Councillor Parton. So just to come to that question, this question relates to the consultation arrangements, the extent to which we've been able to engage with people and publicise the changes, how we've distributed information, what sort of technique we've used. I think we've got a colleague with us tonight, Richard, who's been working from a CCG point of view with the leadership on the consultation process. Richard, are you able to join and address those issues?
Yeah, I'm here, Andy. Can you see me?
Yeah, I can hear you, Richard. Yeah.
Great, excellent, thank you.
I can see you as well now, yeah.
Brilliant. So thank you very much for the question, Councillor Parton. I mean, we've been really keen right throughout the process to use a range of techniques, both online and offline, to give as many people as possible the opportunity to understand the proposals that are being put forward and to feel as though they can take part in the consultation process should they wish to do so. The kind of activity that we've done to support that includes, as you would expect, a lot of media coverage in both county-wide and locality-specific media, including the Leicester Mercury, Radio Leicester, East Midlands Today, as well as our local weekly newspapers. We've also taken out 3 full-page advertorials across local newspapers, both in the city and in the county. We have taken out advertorials in a number of community magazines and newsletters, those which tend to be serving particularly small kind of communities, including, for example, the Swift Flash and the Hinckley Roundabout. We've commissioned an extensive 6-week radio advertising campaign, which is run across some of our cultural specific and community specific radio stations, covering the city and the counties, including Sabras, Eva, Kohinoor, etc., as well as an extensive 4-week radio advertising campaign on commercial and community radio stations, covering all parts of the city and the counties. We've also been using some quite innovative techniques to use targeted TV advertising to get adverts directly into the homes of residents aged 55 and over, and those particularly less likely to be digitally enabled. and that's reached around about 79,000 homes across Leicester, Leicestershire and Rutland. And then over and above that, what we've also done, of course, is an awful lot of activity using online and social media techniques. At last count, we were able to evidence that our online presence had reached at least 500,000 social media users across Leicester, Leicestershire and Rutland. So in total, a kind of huge amount of activity, some of which has been quite high tech and cutting edge, some of which has been a bit more local and specific to particular communities of interest that we want to work with. I guess one of the things that I've been particularly pleased by as a measure is the number of people who have been able to access our consultation specific website. So since the consultations launched at the end of September, we've had more than 80,000 unique users from LLR who have accessed the consultation website, looking for information on the consultation process, having been driven there by seeing some of our activity elsewhere. And I think that's a real measure that we've been quite successful, very successful in fact, in getting the messages out about the consultation process and supporting people to take part in the consultation if they wish to do so.
Thank you, Richard. That's, I hope that addresses the question, Councillor Parton. It's a really good question, one we've been asked quite a lot, and I think, as you can hear from Richard, we've tried a very broad approach. So I hope that gives you some reassurance about the way the consultation process has worked and is working. We've got two more questions now. Emmy and Dominic, both related to maternity services. Emmy's question is about the feeding service and whether it will support mothers with not just breastfeeding, but feeding generally, regardless of which option they've opted to go with for feeding their child. And Dominic puts the question about the extent to which the design for the midwifery lead centre has been led by the midwifery team and by midwives themselves. So Ian, perhaps I can turn to you on those questions.
Yeah, I won't pass this one to Mark, that's fine. I think they link actually, the two questions, Andy. I think they integrate actually quite nicely. The first thing to say is we don't have detailed designs at the moment for the standalone midwifery unit at the General, because this is a consultation and we're 4 years away from actually having completed the work, assuming that we go ahead as planned. But I think this is not about the buildings in the end of the day. This is about the care around the woman. And many people on the call, I hope, will have heard of what's called the Maternity Transformation or Better Birth, which is a national programme which is intended to increase choice and increase personalised care for women during their pregnancy. And in particular for women with uncomplicated pregnancies, there's a very strong element of that, which is to increase continuity of carer. So the expectation is that over the next 4 years, we will be developing a model of midwifery care in particular, which will be very largely around a small team of midwives, probably between 6 and 8 midwives, providing all the care for a woman from the time that she comes along to say that she's pregnant through to the point at which she's discharged from any midwifery care after her postnatal care at home is complete. And what that means is that what we would expect and what we're really enthusiastic about trying to do is to develop a model whereby that team can take responsibility in the community, in the birth centre, and then for the woman once she's gone home, and can support her and her baby with whatever feeding and other needs that they're liable to be. Now, we would suggest that where possible, breastfeeding is likely to be best because there are lots of benefits in breastfeeding, but we also would emphasise that women shouldn't be forced to do something that they're really struggling with or that's not right for their baby in their circumstances. And so it absolutely would be the case that we would be expecting those teams of midwives in the postnatal care to be providing support in whichever was most appropriate for that woman and her baby. We will also expect that those teams will be playing a substantial role in developing the designs and the layout and the way that that a standalone midwifery unit will work. And we really want to use the expertise and the experience of the Melton team of community midwives and the Melton staff that are responsible for the standalone birth centre at Melton, because they have clear experience and expertise, which is really valuable, and we're really wanting to bring them on board to engage with a pathway for uncomplicated midwifery care. And I have to say, I think that there are potential advantages for us now in being able to put this together as a county to create a model within maternity transformation which has a real national identity as being an exemplar from the point of providing care in the community, including home birth, care in a standalone birth centre for delivery, or care in an alongside birth centre. And I think it should be possible for women to move between those different settings depending on what their preferences are at any particular time in a pregnancy. You know, well, as you can see, I think that there are real opportunities to do something really quite innovative and different if everybody really engages with it and goes with it.
Thanks, Ian. That's a really helpful answer. Thank you. We've got a bit of a change of tack in terms of some of the questions now. So I've got a couple of questions in a row relating to the future of community hospital facilities. So the first relates to the community hospital, Fielding Palmer Hospital in Lutterworth, and makes the point about a lack of investment and uncertainty regarding that hospital, and also the plans that in East Lutterworth that might see a fairly substantial increase in population in the area. I'll pick this one up, and I'll also come to the Rutland Memorial Hospital site if I might next. And just to be clear, we've got a really active process beginning with Lutterworth, including local political leaders as well as the community themselves, and a community interest group that's been established that is lobbying for services. We've agreed very positively to work together to look at the future of services in the area, and we've issued not too long ago, a few weeks back, or maybe a month now, a sort of a joint statement saying how that work was going to progress. It does rather depend on what happens with Lutterworth East, and there still is some further work to do there. So we're trying very hard to make sure that the plans for Lutterworth reflect the health plans for Lutterworth reflect the place for plan for Lutterworth, but there is a very clear commitment, I think, to try and develop and increase the range of services delivered in Lutterworth, as there is in fact in Melton and in Hinckley and in Rutland actually, and I'll come on to that next. One of the key questions to answer is, what do we do about the physical facilities that we need, and that does rather depend on whether or not we're going to have access to funding linked to the development of East Lutterworth. You know, will there be a second site, those sorts of issues. So we're just evaluating those, and we hope to provide with the community's leadership, if you like, plans for the future of service delivery in Lutterworth over the coming months. So we've begun a pretty active process on that, I think. Similarly, there's a very active process in Rutland. We had a meeting less than a week ago, actually, as part of this process, specifically in Rutland, and talked a lot about the developments that have already taken place to increase the range and scale of service provision in Rutland, including in the hospital there. I was able to give a very clear and unequivocal commitment to the future delivery of services in Rutland. The key issue for Rutland to decide for itself, really, and we were very clear this is a place-based decision that we'll make through partnership working with the council, with the community, and with primary care network in Rutland. You know, what is the future for the hospital? Do we redevelop and enhance it? Do we think about replacing some of what goes on there with new facilities? We have no firm plans yet, but there is absolutely no question of us simply closing that hospital. I think the issue is much more about the extent to which we either redevelop it or replace it, recognising that it is quite a landlocked site and parts of the facility are quite old. So, but the commitment we gave is decisions about that will be made in Rutland by Rutlanders for Rutland, and not imposed externally. And I could make the same commitment really to kind of Lutterworth, to Melton, to Hinckley, to other places where we're trying very hard now to work with the communities to develop meaningful plans for each of those communities. So we're absolutely working on those issues. I've got a question that goes back to Richard. I think some of the comments you were making about consultation, just asking the extent to which we understand how the messages are being picked up by different parts of the community. This question talks specifically about different age groups and whether we're happy that we're getting the right kind of profile, and if not, what we can do about that. So perhaps, Richard, would you like to just say a little bit about that?
Yeah, of course, Andy, thank you. So we've been really keen to try and make sure that at the end of the consultation process, when we look at all of the responses that we've received, that we've got something which feels as representative of the population of Leicester, Leicestershire and Rutland as it possibly can be. As a result of that, we've been monitoring the consultation responses that we're getting on almost a daily basis, actually, looking to make sure that we're getting responses from both the city and all areas of the county, that we've got people responding from all of our different diverse communities, and that we've also got people that are responding right the way across the age brackets. And where we've identified that we think there might be particular challenges, we've used that to adapt and improve our communications approach. And in part, that goes back to some of the things which I was describing earlier on. So very early on in the consultation process, what we saw, perhaps unsurprisingly, given that we're working in a pandemic and a lot of our activity has been doing online, is that we saw a real spike in responses coming from people via social media platforms, particularly Facebook. Naturally, that tended to be coming from people who tended to fit into the kind of 20 through to 50 age categories. And we were a little bit concerned that we weren't necessarily seeing the responses that we wanted from people who were older than that. So what we did is we redoubled our efforts around some of the media which we know some of those older people tend to be consuming, including their local weekly newspapers and listening to those radio stations which are broadcasting into the hearts of their communities, as well as some of that specific TV advertising that I was talking about earlier on. What we've also been doing is working specifically with the voluntary and community sector. So we've partnered with 18 voluntary and community sector organisations in total, each of whom has got a slightly different remit to reach out and work with specific segments of the community. And that covers all protected characteristics, including age, race, sexuality, etc., etc. So I'm really hopeful that when we get to the end of this process, when we look at the totality of the responses, we're going to have something which really looks and feels, broadly speaking, like the population which makes up Leicester, Leicestershire and Rutland.
Excellent, thank you, Richard. That's really helpful. And there is a second question from Councillor Parton in this area, just seeking clarification about the timetable for considering the comments we receive, what we do with them, and whether we would then reconsult in the light of any changes that we make. So would you like to talk to that? I might chip in a little bit as well, but perhaps Richard, maybe I could come to you first.
Sure, of course, Andy. So as Councillor Parton will be aware, the consultation concludes on the 21st of December. It will then take us some time, as you would expect, to work through all of the responses that we receive. We've been doing that as we go, but clearly there will need to be a process at the end. We expect that that will probably take us at least a couple of months before we're in a position to take something back to the clinical commissioning group governing bodies that outlines the feedback from the consultation process and makes a final set of recommendations for them to take a decision on. At that point, unless we are proposing something which is significantly different to what we've been able to consult on previously, we wouldn't necessarily be looking at a secondary consultation process. That would have been concluded from now. What we'll be doing as part of that work is demonstrating how we've listened to what patients have told us and the public have told us through this process, how we've understood those issues and concerns, and how that's been reflected into our final position.
Brilliant, thanks, Richard. I don't think I need to add anything at all to that. That's a great answer. Thank you very much. I hope that addresses the question raised. I'm told we have got a question which Dominic has put that we're struggling for some reason to kind of publish, but I am aware of it, Dominic. So I think the question that's been put, and I'll put it to you, Ian, if that's okay, is the extent to which the midwifery leadership has also been involved in and has endorsed these processes. So perhaps you might just want to talk a little about that.
Yeah, sure. Well, the short answer is yes, at all stages and in all situations. I think just to explain the process, when we've had these different what we call option appraisals, there have been very wide contributions from all professional groups, including obstetricians, anaesthetists, neonatologists, a very large and wide contribution from midwives of all persuasions. So midwives that work in delivery suite, in antenatal services, in management leadership roles, and in community roles. And also, dare I say it, midwives who now work in clinical commissioning and have some responsibility for clinical commissioning of services. And so the option appraisals have all been contributed to by people who have a midwifery background. And it's the option appraisal that then has led on to the development of what we call models of care. And the models of care have been designed to take into account the pathways that women will need to follow, depending on whether they have complicated or uncomplicated pregnancies. And midwives have been absolutely central and integral to discussing those models of care and establishing the best way of providing services to women, whether they be uncomplicated with straightforward normal pregnancies or very complicated with difficult pregnancies that require specialist midwifery input, as well as consultant and other medical input. We have a women's hospital project board, which is substantially contributed to by senior midwives, and their standing members. So Elaine Broughton and Kerry Williams, and the matrons, if they need to be involved, are all involved in the Women's Hospital Project Board, and will be central to the way that all the services are designed and built. We also have done some peer review at this stage. We've had some conversations with Barking and Havering, who did a similar type of process a few years ago down to the east of London. We've spoken recently with Manchester, who also had a similar process a few years ago with a new build, and also with Dublin, who at the moment the National Maternity Hospital in Dublin is pursuing a similar process of moving their hospital and developing a new site and a new service. And as part of those conversations, it's been absolutely critical that we've had midwifery involvement on our side, and that we've had an opportunity to speak to midwives as well on their side, because without doing that, we can't possibly develop a sensible maternity service.
Thanks, Ian. That's a really clear and comprehensive answer. Okay, I'm just going to take stock because we've been working now for just over an hour and a quarter or thereabouts. I think we've managed to work our way through all of the questions that have been put forward, so I hope that's the case. I hope I haven't missed anyone. I don't think we have. I think we've been able to answer pretty directly all the questions, so I hope that's been helpful to people. Thank you very much indeed to everyone who's participated, and particularly to colleagues who've put questions. Thank you. It's the questions that you've asked, I'm sure, will be ones that many other people would be interested in hearing the answers to too. And of course, this process enables us to share that. We, as you can see, just coming up on the screen now, we still are actively consulting. That process still runs for a little while longer. You can see details there about how you can contribute to that consultation, and we certainly would encourage you and anyone else you can commend this process to participate and to share your views with us in the ways that you can see on the screen. The more consultation responses we get, the richer the picture we get, the better our final proposals will be as a consequence. So thank you very much indeed for those comments, and please take the time to complete the forms if you're able to. Thank you very much to colleagues for participating and answering questions tonight. It's great to have a range of colleagues with us. I hope between us all we've been able to address the concerns and certainly listen to the comments you raised. I don't think we have any further questions in, and we're close to the end of our time. So I'm going to suggest we close now. Thank you very much indeed Good night, and I hope you found this event useful. I look forward to an opportunity, perhaps in the near future, to talk to you some more, and certainly in the new year when we share the details of the outcome of this process and think about what the next steps look like. I'm sure we'll have a chance to talk again. So for now, at least, goodbye and thank you very much.